Good evening. I'd like to acknowledge that Dalhousie is located in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq, and pay my respects to the elders. I am Dr. Rebecca Affoo, a speech-language pathologist and an assistant professor in the School of Communication Sciences and Disorders in the Faculty of Health at Dalhousie University.
And I am Shauna Hachey, an assistant professor in the School of Dental Hygiene. Both Rebecca and I are co-leads of the Dalhousie Healthy Populations Institute Flagship project, putting oral health is health into action. This flagship is committed to improving oral and overall health status of Nova Scotians by enhancing oral health strategies and accessibility through interprofessional research. Rebecca and I are your hosts for this evening's Open Dialogue Live, Oral Health is Health event.
Welcome to all our viewers and our panelists. We're thrilled that you could join us this evening for this discussion as we explore the current issues in oral health care faced by Canadians across the lifespan, from children under care of the government to aging populations in long-term care facilities. And this is a very timely discussion tonight as it is Oral Health Month. So please welcome your panelists for this evening. Dr. Tracy Doyle is the director of the Dalhousie Paediatric Dentistry undergraduate curriculum, the Associate Chief of Dentistry at the IWK Health Centre, and a clinical director for the Special Smiles program with the Special Olympics.
Dr. Carolyn Mitchell is a primary healthcare nurse practitioner with Nova Scotia Health and is an assistant professor in the School of Nursing at Dalhousie University. Her area of research covers the healthcare needs of children in care and the effects of adverse childhood experiences. She also has an interest in supporting the patients of all ages living with multiple chronic diseases and complex care needs.
Dr. Brandon Doucette graduated from Dalhousie Dentistry in 2019 and has since been a practicing dentist in Pasadena, Newfoundland. He's the founder of Coalition for Dental Care, a group that highlights the shortcomings of our existing dental care system and advocates for a more humane alternative.
Mr. Floyd Prosper is a dental therapist in the First Nations community of Eskasoni, Nova Scotia. He graduated in 1994 from the National School of Dental Therapy. In his early career, he spent time in the Canadian Arctic and is now working out of Eskasoni Elementary School, as well as Member 2. He is committed to serving his community and improving oral health and overall health outcomes.
Dr. Mary McNally is a professor and associate dean of research for the Faculty of Dentistry at Dalhousie University, where she's been a full-time faculty member for over 20 years. Her academic interests include caring for elders, oral health promotion, and healthcare ethics, focusing on social justice and access to care for priority populations.
To begin our discussion this evening, we will ask a few questions to each of our panelists, and then we will open it up from questions from our viewers. Brandon, you are an oral health care provider in Atlantic Canada. From your perspective, why is oral health important, and how does our current model of oral health care, which is primarily privately delivered, meet oral health needs?
So to start, it's important to remember that the effects of poor oral health go beyond the mouth. So it can affect general health conditions like diabetes or heart disease, but it can also affect things like economic mobility. As you could imagine, it's difficult to find a good paying job if you're missing front teeth or if you have visible decay. And our current dental care system treats people based on their ability to pay, and very little is allocated to those who don't have insurance or who can't pay. In fact, targeted government programs account for an even smaller percentage of dental spending in Canada than even the Americans, which is a pretty low bar. Even with these targeted programs, we see 1 in 3 Canadians lack any form of dental insurance, and over 1 in 5 avoid the dentist each year due to financial constraints. And even before the pandemic, these things were getting worse. So a lot of people are retiring and losing their work-related benefits, and a lot of people are working in the gig economy, which doesn't provide benefits like dental insurance. Now, with COVID-19 and the financial hardship caused by that, things are getting even worse. So this results in people neglecting routine treatment so that they can focus money towards dealing with pain and infection. And when this happens, those smaller problems only grow and get worse. So this results in people coming in very late stage, and it's not uncommon for me to see people coming in needing all of their teeth extracted. And I know these people have been living with pain and infection for years, and you need to help people where they're at, but I mean, they shouldn't have to come in at such a late stage. And this neglect, it results in a lot of suffering, but it also is like causes added healthcare spending as well. So it's estimated we spend about $150 million per year nationwide on patients going to the doctor for dental pain, which is very inefficient. For these reasons is why I founded the group Coalition for Dental Care, and why I think we should move away from our private dental care system and to understand just some of the limitations of kind of the targeted program model that we've been pushing. And like targeted programs, they have limits politically because, you know, they're able to be kind of demonized as people getting free stuff. Whether we like it or not, I don't. They do have that weakness politically, which leaves the people relying on those programs to struggle to find a dentist who will even accept them on those programs and will favor, you know, having their teeth extracted rather than saving their teeth. Universal programs, on the other hand, are much stronger politically as everyone buys into them, which makes it much harder to cut funding because you face a much broader backlash. And I think it's time that we as a society build a dental care system that ensures everyone has access to high quality dental care, regardless of ability to pay. And the current system isn't close to that.
Thank you very much, Brandon. Those are very important points. Tracy, I'd like to turn it over to you now. What specific oral health related issues do individuals with intellectual disabilities or special healthcare needs experience?
Well, thank you, Rebecca, and thanks for everybody for having me. I guess the first point I'd like to make is that it's great to recognize that different populations have different access to oral health care, whether that is because of some of the programs that are targeted towards specific populations or not. As a clinical director with the Special Olympics, we screen athletes on site for games. And through the Special Olympics, I've learned that oral health care is one of the top unmet healthcare needs in the population of intellectually disabled, in this case, mostly adults and teenagers. And a significant percentage of adults with disabilities, including intellectual disabilities, don't have a dental home. And as a pediatric dentist, I strongly advocate for the establishment of a dental home by 1 year of age for all Canadians, of course, and Nova Scotians. And so the population of people that we screen, we see a very high prevalence of untreated dental caries and untreated gingival diseases. And this is for a number of reasons. So this population has very specific barriers to accessing care. A lot of these individuals have comorbidities with their associated disabilities. And so they have a lot of experience in the healthcare system at a young age. So, you know, we call it the picked and prodded sort of syndrome, where they have a lot of fear and anxiety towards medical care, which extends then to dental care. Particularly my population of with autism spectrum disorders, for example, often have oral aversions, which of course hinder the provision of standard dental care. A lot of the individuals that I meet through the Special Olympics also have a lack of, perceived need for dental care. They feel like unless they have pain, they don't really need to go to the dentist. So they don't understand the importance of routine preventive dental care as well. a lot of the patients and a lot of the individuals I see too are that they have an inability to tolerate routine dental care. Some even rely on advanced sedation and general anesthesia. And this particular population or percentage of the population definitely have even greater restrictions to accessing care. As we know in all across Canada, there's limited access to day surgical care in hospitals. And some of our patients just have the inability to communicate dental pain and other sources of oral pain. So of course, their caregivers, if they don't recognize the need, then they often don't receive the care that they deserve and they need. To echo Brendan's sentiments, cost, the financial burden of dental care. Dental care is expensive, is also a great barrier. Some of my athletes kind of fall through the cracks that they aren't really eligible for the provincial care for those with intellectual disabilities, and may be receiving social assistance and other kinds of income assistance. So really don't have any private benefits, don't fit the criteria for the provincial programs, so therefore don't have any means for paying for dental care. Some have difficulty with physically accessing care, much smaller proportion, but a lot of my athletes tell me that they do rely on others to take them to appointments or to remember when appointments are. So they rely on alternate caregivers, whether they're family or group home workers. And sometimes dental care takes a backseat to other types of medical priorities. And there's just not enough time in the day to make to all these timely appointments. So yes, the reliance on alternative caregivers can be tough for some of the athletes to therefore get the care that they need. We also have, we know from some of the survey research that's done across Canada that we have a problem with our intellectually disabled population finding a practitioner in the community that feels they have the experience to address often the special needs that the person may present with. And then alternatively, we have surveyed our dental colleagues as well, and there is the sentiment that a lot of our graduating dentists don't feel that they've received enough experience, clinical experience and didactic experience with special needs dental care, and then therefore don't feel that they are able to treat this vulnerable population. So those certainly are factors. In addition, a lot of practitioners feel sometimes that the extra time that's required may be a bit of a hindrance for caring for the population, and often may then refer for specialist care that also comes with long wait times. So for all these reasons, I see in the 2018 data that came out of the National Special Olympics that were actually held here in Antigonish, that many of our dental faculty were able to join, both students and faculty. We did see out of all our athletes that were screened, about 20% presented with untreated dental disease, so open dental cavities, and another 40% presented with signs of active gum disease. So again, oral health tends to be one of the most top unmet healthcare needs for the special needs and intellectually disabled population.
Thank you for sharing your point of view, Tracy. Mary, why is oral health important as we age? And what specific oral health related issues do older adults experience, both those living in community and those in long-term care?
Well, thanks, Shauna, and thank you for having me. I think it was a nice lead-in with Brendan and Tracy both, because there's a lot of overlap with the issues that they've raised already. So I guess, as older adults, I mean, there's a broad spectrum of older adults, of course, not everybody's the same. A broad range of fitness to frailty and ability and so on. But really, as you age and as we do become more frail, there are three things that kind of come together that I'd say I could boil it down to 3 things that kind of compound our risk for oral disease. And so one is just chronic conditions, medications that people take that actually change the microenvironment of the mouth and make make the mouth make people more susceptible to oral disease, principally dental cavities or dental caries. So that's one thing. And medications are known to, many medications are known to cause dry mouth, which is a, saliva is one of the best protectors we have of the health of our oral cavities. So that's one big issue. Another big issue as we age, and again, our abilities change because of aging, self-care becomes an issue. So we may lose some of the dexterity, we may lose a bit of our eyesight, physical strength. Dental care, self-care is actually very technical and very intricate. So frailty and even early dementia, minor dementia can really impact someone's ability to carry out all of the technical aspects of self-care. So that's 2. Then third, and Brandon touched on this a lot, was access to care. And there's lots of things that compound in this way as well. It could be geographic. It could be no longer being able to drive yourself. Stairs, like mobility, accessibility, to offices that can really impact a person's ability to seek professional care to offset the other risk factors. And as Tracy mentioned, there's actually an issue with older adults also having no dental home. If you again don't have the mobility to travel as you used to, or you need someone to accompany you, it can really limit your access to your own maybe regular dentist perhaps, but certainly can impact. And so that can be really problematic. So the long-term care, like very few people actually in the population live in long-term care. We have a huge number of older adults. There's only about 10% of people over the age of, it's probably 70 now, 70 and on up in total, that would live in residential care. And that percentage goes up a little bit as you get older. But it's not very, so people like even over 80, there's a huge proportion of the population that live in the community. So there are a huge number of people who are facing these issues. And the data is really tricky to get because population surveys don't include, the Canadian Health Measure Survey doesn't include people over the age of 80. So right off the bat, this huge population, as we know, baby boomers are aging. And so there's this real bubble that's hitting that higher risk age group. So that's a real problem because we don't even know really what disease rates are. We have a pretty good handle on disease rates in long-term care. Disease rates are high. And by that, I mean dental caries, which is the biggest cause for tooth loss. And then, of course, function and speech impacts social interaction. So it can have a lot of implications, again, as Brandon raised, in terms of it may not be seeking a job, but it may be going to the dining room to enjoy socializing. So it can be really impactful. So just my last point I'll make is kind of the importance with maybe thinking about the fact that older adults may have less access to professional care in dental professional care for a variety of reasons. It's really important that a broader spectrum of interdisciplinary health professionals start to notice this 4 cubic square inches of the mouth and not look past the mouth into the throat. So we're really important to raise awareness amongst nurse practitioners, primary care nurses, physicians, and especially in long-term care, because people who care for someone else and are responsible for their personal care, as I said, is very technical. So doing it on someone else is highly technical as well. And so I'll just put a little plug in for a website we've developed over the years called Brushing Up. Well, the program's called Brushing Up on Mouth Care, but the website is it's just brushingup.ca. And so there's a lot of resources there that are directed toward personal caregiving, caring for someone else, and a broad spectrum of resources there. So I'll kind of end there, and happy to come back to any questions to fill in the blanks.
Wonderful. Thank you so much, Mary. And that was a nice interdisciplinary segue. Because Carolyn, now I would like to turn it over to you. Your experiences with children in care, and I would like to know what concerns you have related to this population.
Thank you, Rebecca. And thank you, Mary, for the plug. I'm a primary healthcare nurse practitioner and have been one since 2007. I've worked in numerous communities across this province, and the care provided to children in care has stood out as being concerning to me. I have seen numerous children. One particular clinic I worked in, we had a large number of children who were in the care of the province, and who, because we were a community clinic, we were approached by the social workers to provide care to those children. So providing care to a child who you've never met before entails a full head-to-toe assessment and gathering of a health history. And the one thing that actually stood out to me was the poor dental hygiene of the children in care that I was seeing. And I think, you know, as well, Tracy's comment about children on the autism spectrum disorder, a lot of children in care may have other significant healthcare issues, which would contribute to actually their ability for them to care for their own teeth. And you can just imagine that if a child is apprehended by the province, they're coming from a family that's disrupted for one reason or another, who are not able to provide care to their children. So you think that preventative health and preventative care would be sort of always on the back burner because they're dealing with other things in their life. But in my course of my work and identifying the needs for children, and dental care was one that stood out. There were many others, but I did, in this particular clinic that I worked in, I did a chart review actually for my doctoral work. And one of the things that stood out when I actually went back and looked at all the children that I had seen and did a chart review was that 76% of the children in care that I had seen either had significant dental work before I saw them or required significant dental work. And you can imagine, as Mary says, the small area can cause tremendous difficulties. So if we think about how well a child is coping, their growth and development, we know that poor oral hygiene and dental pain can cause problems with eating, right? So if they're not eating, they're not necessarily getting the nutrition that they need for their growth and development. It can interfere with their ability to communicate. It can interfere with their ability to sleep and to perform in school and to pay attention if they're in discomfort. So when we look at all of those components when we're caring for children, and as a healthcare provider being one of those team members when the province is responsible for caring for these children, we want to ensure that we're optimizing their care. So just as I ensure that every child was up to date on their immunization, I wanted to ensure that their dental health needs were taken care of. So once again, as Mary mentioned, lack of access to primary care provider is a huge issue. But when we work in different departments, health, community services, and we're working in silos, one of the other things that we have to remember is when a child is apprehended and taken into care, there is no primary care provider for them. Because if a child is apprehended in Yarmouth, they may actually wind up in Halifax in a foster home. And so if they did have a provider, they're nowhere near their provider to have the care that they need. So being the primary care provider, then attaching them to, and 76% of them have significant dental health issues. Most of the time they require sedation to actually do that dental repair, which cannot be done in a community clinic. As mentioned, the lack of experience with dealing with children with special needs, and also trauma-informed care is very important for these children as well. So in our particular clinic, I made connections with the local pediatric dentist who actually would see every child that I saw that came into care and would do a full dental assessment on them. Because once again, as primary care provider, that's not my area of expertise. But we would streamline the process. So I would refer to the pediatric dentist. They would see them within a very short period of time, which was very pleasing, when you're used to long wait times. And then they would be provided the care that they needed. So right then and there, the child's dental health needs were taken care of. But the big thing that stood out was the lack of coordination of care. I have never run across a healthcare professional that I have ever asked to or referred a child to who would refuse to see a child. But I think we're working in silos, and those silos create a backlog, they create delay in care, and streamlining the care is most important, especially when children are being moved across the province and their time frame to be provided care is limited.
Thank you, Carolyn, for your work and being such a wonderful oral health ally. Floyd, lastly, we would like to hear from you. As a member of an Indigenous community and as a dental therapist with over 20 years experience, can you please share with our audience what the role of a dental therapist is?
Yeah, so I've been working as a dental therapist for 25 years or so. And I started out in the Arctic, and where access was very limited, and care is often in these remote areas very sporadic, itinerant, transient type work, and this is what dental therapy is not. So, and this is what communities need is this type of service delivery that provides a real continuum of care. So I see that as my role as a dental therapist in my community as well, where there's a continuum of care, filling the gaps and making sure that you're providing preventative care as well. Now we're a bit more fortunate in this area. We're not so isolated, but there are still gaps in care, I believe, and that's where dental therapists, I think, play a huge role in reducing the disease burden on our reserves, which we all know is larger in many respects in our health and in our lifespans, and all kinds of diseases because of the conditions that we often live under on reserves.
So from your perspective, you've touched on a few, but what would you say is the burden of oral disease and the barriers to accessing oral health care for Indigenous people?
Oh, geography is one of the biggest things. You know, the location of some of these places, you have to fly into a lot of these reserves up north, especially in the north, northern Manitoba, Saskatchewan. And what, like I said before, the care that they would often get is sporadic and itinerant type work, and this doesn't address the needs of the community to have those. You know, to have that continuum of care and to address the education component of oral health care, and to provide preventative care that can have longer lasting effects for a community as a whole.
And for those who are most familiar with the dental hygiene, dentistry model, as a dental therapist, what services are you able to provide?
Well, just basic dental care. You know, there's a scope of practice that we stick to, and that's the benefit of the dental therapy program, that, you know, there's a scope of practice and a quality of care that's tried and tested over time. And so anything that's beyond our scope is referred to a dentist or specialists. And you know, we do lean to dentists for that type of care, and the specialists as well. But the care that we do and can provide is quality work, the basic dentistry and the basic extractions that dental therapists do. It's been studied over and over again, and it's always been proven that dental therapists can provide dental care that is equal to what dentists can provide.
Excellent, thank you.
Thank you so much, Floyd. We are now going to hear from our panelists about potential recommendations and solutions for improving the oral health of Canadians. So Brandon, I'd like to start with you. You highlighted a number of issues with the current oral healthcare system. What are some recommendations that you may have around that?
Sure. So myself and us at the Coalition for Dental Care, we're advocating for a system that looks very different than the one we have. So first, we want the expansion of Medicare to include dental care to make sure people are guaranteed dental insurance throughout life. When people lack insurance, they go long periods of their life where they just don't get preventative care and early intervention. And, I also think people shouldn't have to worry about losing coverage if they become unemployed, if they retire, or even if they leave a relationship where they rely on their partner's insurance. Also, with this universal type approach, we remove the discriminatory tiered system where dentists prefer treating patients with good insurance over people who don't have that, because dentists would be paid the same amount regardless of a patient's income. With this said, I also think we can improve on our Medicare system where we publicly fund private clinics. And I also think because just having dental insurance doesn't guarantee you have a dental provider nearby, as some of the other panelists have mentioned. And for this reason, I think we need a strong sector of easily accessible, publicly owned dental clinics in places like schools, long-term care facilities, rural and Indigenous health centers, and places like prisons. This also allows us to hire staff on a salary rather than the more expensive fee-for-service model, and it allows practitioners to spend the time needed with patients who have those more complex needs. Also, public ownership allows us to bring dental therapy into the mainstream in Canada. As Floyd mentioned, dental therapists can do procedures like fillings and simple extractions at a fraction of the cost of a dentist. And this means our tax dollars can go further. And it also allows dentists to focus on more complex procedures for which, only they have the training for. And in order to get this done, I think it's important, to bring the provinces on board with this. I think the federal government can offer a generous cost-sharing agreement with the provinces where, these payments are conditional like we do with our Canada Health Act. So these legally binding principles can include things like comprehensiveness, accessible, portable, universality, and public administration. And if you don't meet those standards, you don't get help with funding. And, if dental care in Canada were put to that test now, it would fail in every category. So I think this is a great legally binding mechanism to help make sure we raise the standard of dental care across Canada.
Thank you very much, Brandon. Tracy, what is currently in place to address some of the issues that you have highlighted, and what are your recommendations for change?
Well, I guess, Shauna, to begin, it was a study done in 2010 that looked at all the dental school curriculums across Canada, and there certainly is no standardized curriculum to address dental care for special needs populations. And so in our own curriculum, in our final year for our senior students, we've every year tried to add to our basic curriculum so that the special care needs of those with autism spectrum disorders or cerebral palsy, those with seizure disorders, just to name a few, at least this information to begin is being delivered didactically. And there's a national organization called the Canadian Society for Disability and Oral Health that any oral health practitioners and allied professionals can become members of. And certainly the executive is starting to advocate and contact dental schools across Canada to hopefully add more and more to the curriculum as time goes on. So I think, didactic education is only one aspect, though, to make a practitioner comfortable to therefore graduate and then provide care again to the vulnerable populations who are seeking care. So, I've been trying my best within my role as a professor at the Faculty of Dentistry to give my students as many experiences to interact with those with special healthcare needs. We've had did rotation for senior students for many, many years. And my team that I take to all our well, once national, but now provincial games is heavily made up of volunteers from both the faculties of dentistry and the School of Dental Hygiene to give some hands-on experience with interacting with the population. Most of the athletes that I interact with can be treated in a community dental setting with very few modifications for care. I say, it doesn't take much to deliver respectful and compassionate care to this population, and really experience is key. And I always call it my retirement plan, but one of my goals in my career, I think Nova Scotia would really benefit from a multidisciplinary special needs care center for our older teenagers and our young and older adults, particularly with intellectual disabilities, that hopefully will be strongly affiliated with Dalhousie to provide that educational component. Because I think within an educational setting, it's easier to deliver that multidisciplinary and comprehensive care that this patient population certainly deserves. So hopefully, with improvements in both the didactic and clinical experiences, our future graduates will be happy to welcome our patients with special needs into their practices, and so that everybody ultimately has a dental home.
Thank you, Tracy. That's awesome. And that multidisciplinary clinic sounds amazing. Mary, I'd like to turn it over to you, and I would like to ask you the same question, but get your perspective as it relates to aging. So what is currently in place to address some of the issues that you've highlighted, and what are some of your recommendations for change?
Yeah, that's a toughie. I mean, because as I said, so many of older folks still live in the community, and so would just face it almost like Tracy was just saying with special needs populations, that just modifications to what general dentists are doing. There are no geriatric specialists. There's no specialty in Canada for geriatric dentistry, so it's really up to general dentists to look after it. So again, to reiterate what Tracy said, that really important to enhance the skills and the experience. It does take a lot of experience to get better at it, and even just modifying where we put our emphasis, more prevention oriented, to actually manage the chronic disease rather than kind of fix teeth. So that's a really key role. In Nova Scotia, I will just again sort of put a bit of a plug for long-term care. A lot of advocacy was done in Nova Scotia over the years, and Nova Scotia has been very progressive in putting in place a requirement for every person who enters long-term care to undergo an oral assessment within a matter of 3-4 weeks, and that they have to have a care plan for oral care. And up until 5 years ago, that didn't exist. So and it's patient-centered. It's not so prescriptive that it's a deterrent. It's the assessment is actually done by the nurse manager or an RN, and there are some training materials, some education materials in our brushingup.ca around the oral health assessment and actually development of a care plan arising from that. So yeah, and I always tell students, they're going to be busy looking after baby boomers and older. So really, that hopefully will follow the need, the experience and getting better at it will follow the population and the population demands.
Thank you, Mary, for further highlighting the need for the interdisciplinary approach to oral health. Carolyn, you pointed out that children in care face unique challenges in accessing and maintaining continuity of care. How do you think we can overcome these challenges?
Well, I think coordination of care, when you talk about having community dental clinics, it's not any different than we talk about having a medical home for every person in Nova Scotia, to have community collaborative clinics where you have multiple healthcare professionals working together. And I see the need for children in care is quite high in the dental provision of care. But definitely having a medical home for every child in care, for every person in Nova Scotia, that includes, and we move away from our silos, away from mental health as being separate from the physical body, and oral health as being separate from the physical body, and bringing it all together and working collaboratively as healthcare professionals to provide that health home for people so they provide all their services. And I think probably the biggest thing that stands out for the children in care, we know that dental care is covered under the provincial health plan for children, but that doesn't mean that children are receiving the care that they need. So I think we need a multi-pronged approach. We need that education about the importance of dental hygiene and the importance overall of the dental health for the individual's overall health. But we also need to look at breaking down barriers and addressing those fears that people may have with having previous dental experiences, or maybe just having children come from families who have never practiced dental hygiene or have had any connection with a dentist. And how then do you start to introduce that child to caring for their teeth when their parents have never saw that as an important factor? But I think the other thing for children in care is that we need to have more data. We need to know what are the needs of children in care, and we don't have that. There is no repository of information that we can draw on that identifies what their actual needs are. From my personal experience and from my simple chart review, I see that there's a high need for dental care, but there are other needs as well. So we need to have that data so that we can actually make informed decisions on what is the proper care. But the first step is having a health home.
Thank you. And we're very lucky that you're helping to tackle these important issues. Floyd, I'd love to turn it over to you now. You've highlighted the deep-seated inequities that Indigenous people face and how they affect oral health and oral health care. How would you like to see things change?
Well, we're seeing changes already. We haven't had a dental therapy school in 10 years, so there's prospects of a school opening up soon in Saskatchewan with, I think it's the University of Saskatchewan partnering with the Northern Tribal Council Health Authority. So that's a positive change. It'll fill in the gaps because we're retiring, a lot of us, and getting older. And there's no real repository, I guess, of dental therapists to fill these positions. So that leaves a huge gap in the north, especially in the north. There's a lot of vacancies, and dental therapy has proven that they do fill this gap. And it's recognized even more now that they've been out of the scene in the training of dental therapists for 10 years. So it's becoming recognized that we need to bring it back. Okay.
Thank you. Thank you very much, Floyd. And thank you so much to all of our panelists for providing your expertise and your knowledge on this timely topic. Throughout the session, our viewers have asked questions, and so we will now take a few minutes to pose them to our panelists.
So the first question we have here comes from Aaron Prosper, who I believe might be a family member. So he asks, considering that the formation of a national dental program has been a prominent issue, so for example, last federal election, and has been highlighted in the panel, what are some of the more significant obstacles or barriers that currently exist for a nationally funded dental program to become a reality? Brandon, do you want to start us off on that one?
Sure, yeah. So, I was excited to see the NDP dental care plan to offer dental insurance for families making $70,000 a year or less in the last federal election. To put it in perspective, it would be the single largest investment in oral health care in Canadian history. And, I've spoken with Don Davies, the MP who's proposed this, and it's really he sees it as a first step towards integrating dental care really into our universal healthcare system. And, there is opposition to this. Obviously, there's politicians who don't want to raise taxes. They don't want to spend it. I think it's a pretty easy program to fund, so we can overcome that. But there's also like within the profession as a whole, when the government steps in to take a bigger role, there tends to be opposition from that profession losing some autonomy over the profession. So kind of looking at the history of the formation of universal healthcare in Canada, I mean, doctors were the biggest opponent. And, they went on strike for 23 days. So there's a lot of inertia there in kind of riding off of the status quo. But I think the public is ready for a plan like what the NDP proposed. And I also think they're ready for, more progressive options as well.
Thank you. Does anybody want to add anything to that question? All right. Well, thank you so much, Brandon. That's awesome. Shauna, do you want to read our next question?
Absolutely. And we might be focusing, getting Brandon to start us off on this one as well. So much of the rhetoric that opposes a universal dental care system stems from a financial standpoint. What would your response be to this?
Sure. So I guess I'll start with that again. So I think it's important to highlight that we already spend a lot on dental care, like a lot. And it's not spent through the government. It's spent through private health insurance companies, through your work, and through out-of-pocket payments. So I think it's important that we reconceptualize this issue, because no one would say that the private American healthcare system is more cost-effective than the universal healthcare system we have in Canada, just because the American government spends less per capita than we do, but they spend more overall when you take into account the work-related insurance, the out-of-pocket payment. So it's really important that we look at overall spending for a dental care program. I also think it's important that we look at the benefits of a universal dental plan as well. So, people can go to their dentist instead of a doctor for dental pain. So the $150 million we spend with people going to their doctor, we can basically eliminate that. Also, when we raise the floor, we raise oral health in society, we lower the burdens that it causes. So oral health can cause or worsen many general health conditions. So when people are healthier, there's less healthcare spending as well. There's an interesting study I read on providing comprehensive oral health treatment to people going through treatment for addiction. And what the study found is the people who received dental treatment were more likely to find employment, less likely to be homeless, less likely to relapse. So it's really an integral component to helping lift people up enough that they have a chance at living a dignified quality of life. And there's a lot of costs associated to keeping people in poverty. So I think we should break that cycle and look at the overall costs in society as a whole.
Do any of the panelists want to add to this question?
I can jump in. We were talking earlier, and Carolyn brought up the term silos, which is such a great image. If oral healthcare were better integrated with general healthcare, a lot of the things we've been talking about all night wouldn't exist either. Like the fact that when people conceptualize that this doesn't count as health, that it doesn't get examined when you might go in for hip surgery, when you might have serious oral health problems that could compromise your recovery, things like that. So there's opportunity there if it's thought of as health that would just remove a lot of the other barriers that exist, because we just wouldn't have this perception of it not being not counting as part of the body.
Thank you, Mary. Tracy?
And although Nova Scotia has a publicly funded program that's pretty comprehensive for children, it's not the same as we know across Canada. Every province has different funding schemes for children. Some have no publicly funded dental care for children at all. So we do see a significant amount of day surgical time across Canada being used for the treatment of severely childhood caries, which is a largely preventable disease. And so we see a lot of, to echo Brendan, we see a lot of medical funding to treat a disease that if we could potentially have more universal access to care at 1 year of age for true prevention of the disease. You know, we advocate for that age 1 dental visit for all kids. So I'm putting my pediatric dental hat on and taking off my Special Olympics hat off. You know, if we could truly educate parents at that young age and mitigate a lot of the factors that lead to severe cases of early childhood caries that have all these quality of life effects for our young kids. You know, a lot of our kids have problems, as it said, failing to thrive because they don't eat well. It's, you know, dental caries and the associated pain is one of the largest reasons for missed school days, and therefore parents miss work days, which is a big economic factor. You know, so I would hope that with a universal system, we could count on more true levels of prevention to therefore prevent this disease that keeps me busy and also has a very significant medical expenditure.
Carolyn.
So I just want to say, you know, not coming from the dental world, as a nurse practitioner, when I hear Brandon speak about, you know, your wish to have a community clinic and to have care covered and dealing with the fee-for-service competitor model, basically, it's not unlike the challenges that nurse practitioners have had in the province. You know, we're getting pushback from fee-for-service physicians who feel that we're taking work away from them, when in fact, you know, the overall cost to the healthcare system is less simply because we're spending that time with the patient, because we don't have that burden of worrying about what our, you know, billables are for that day and whether we're going to be able to cover our overhead. And when you take the focus away from the business model of primary care or the business model of dentistry, and you put that focus on the patient, you actually save the province money, because ultimately we're all paying for the services, right? We're paying through our tax dollars. So if we look at getting out of our silos, creating more efficient use of services where we as healthcare professionals all work together and the patient sees the most appropriate provider, it saves a tremendous amount of money. Because when you take that time and you educate somebody about how to care for their teeth and the importance of caring for their teeth, no matter what age they are, you're actually increasing their health, you're increasing their quality of life, and you're decreasing costs to our overall tax system, right? To our healthcare dollars. So I think, Brandon, when I hear you speak, I'm thinking, you know, these are the same challenges we've had as nurse practitioners to say, providing a medical home for people actually saves money. So if I spend an hour with a patient, that is probably 5 visits. They don't have to come into another appointment if you deal with everything in the same visit, right? So really, we're spending the money. We're spending it in different ways. We just need to actually create coordination and efficiency in the use of our resources.
So Floyd, what would you say about the costs of covering dental care versus the costs of oral disease to your community?
Well, can you hear me?
Yes.
Sorry. Well, like I was talking about the communities up north, and if you can run a successful preventive program in an isolated community, you're going to save a lot of money, you know, not sending people to hospitals. And it's going on quite a bit. I know dental therapists throughout the country, and that's a big problem. I know still in Manitoba. It still happens here in Atlantic Canada. It's a huge cost. And I'm glad that Brandon is an ally to dental therapy, it sounds like, and we need more what I would call the renegade dentist these are the types of people that started the dental therapy program. It was dentists, forward-thinking dentists, that created a program. They followed the New Zealand dental nurse program. There was a program in Australia, and they looked into these programs. They knew that they were successful. They knew they were making an impact, and they knew they were saving money. So that's where I stand on dental therapy and cost effectiveness when it comes to delivering dental care.
Excellent. So the next
Thank you so much.
question is if each one of you could, okay, actually, sorry, you go ahead. I think we're posting another one. As a dental student, what are the practices that individuals can implement in their practice to create those supportive environments that promote oral health?
Who wants to kick this off?
Let's start with Mary.
Awesome.
I guess from thinking about older adults as the population, I think we have to shift our paradigm a little bit in terms of providing that preventive care, because we tend to do cookie cutter, and I can say this without malice as a dentist who's involved, but and even catching myself. We kind of have the notion of the 6-month recall or the 6-month cleaning. Well, in my practice with older adults, sometimes I had them come in for once a month deplaquing, and so just trying to get out of our own little paradigms that we stick to that maybe don't make a lot of sense in some cases. I'd much rather see a patient 5 months in a row for a short visit to deplaque than do one filling on a tooth that's, it's probably not going to last if there's high rates of disease. So I guess that would probably be my biggest thing, Emily, would be to think about, ways that you can really address the need and not kind of stick to the way we do things often.
Brandon.
I'd just like to add that on top of kind of education and trying to help patients the best we can, I think it's also important that we look at the fact that there's structural problems in place that make it difficult to meet the needs of certain populations. And I think kind of, working for obviously I have a bias of working for advocacy groups like the Coalition for Dental Care to help highlight some of those shortcomings so that we as dental providers, we shouldn't have to provide charity. We should be, to help people, we should be providing healthcare. A doctor at the end of the day doesn't pat themselves on the back for helping someone who's low income because it's part of their job.
Excellent point. Well, unfortunately, that is all the time we have for tonight. Thank you all for joining. If there's more questions, feel free to post them on the Facebook site, and our panelists will be able to check in and continue this conversation. Thank you very much to Mr. Floyd Prosper, to Drs. Brandon Doucette, Tracy Doyle, Carolyn Mitchell, and Mary McNally for joining us. It has been a great night, and truly, we hope this conversation continues. Thank you to all our viewers for this evening. Stay well, take care, happy Oral Health Month, and remember that oral health is health. Bye for now.